Welcome back. We are on Chapter 22, Diabetic Emergencies and Altered Mental Status. The topics we're going to go over in this section is going to be the pathophysiology, assessing the patient with altered mental status, diabetes, and other causes of altered mental status. In this first section, we're going to talk about the pathophysiology. Normal consciousness is regulated by the reticular activating system. The RAS is responsible for staying awake, paying attention, and sleeping. Brain tissue of the RAS has basic requirements: oxygen to perfuse the brain tissues, glucose to nourish the brain tissues, and water to hydrate the brain tissues. Altered mental status can be caused by many different things: deficiencies in the RAS requirements, trauma, infection, and chemical toxins, primary brain problems, and problems with another body system. Altered mental status is often rapidly correctable by treating the underlying cause. In this section, we're going to talk about assessing the patient with altered mental status. Patients with altered mental status can be dangerous to responders. You always want to consider the safety of yourself and your team before approaching a patient who is acting strangely. Use law enforcement when necessary. Always consider the possibility of an airway and/or breathing problem in a patient with altered mental status. Be especially attentive during the primary assessment of a patient with altered mental status. Carefully watch for indications of inadequate breathing. Be alert to the need for positioning and suctioning, and consider administration of high concentration oxygen if you suspect hypoxia. Be alert for indicators of hypoperfusion. Determine baseline mental status for the patient. This may be accomplished by greeting the patient and assessing their ability to respond. AVPU may help you quickly categorize the patient's initial response. Baseline status can be difficult to determine in children because they answer questions differently than the adults. Altered mental status is a subtle sign that indicates serious underlying issues. A body system exam and complete history may reveal important information about suspected causes. Interview the family members and bystanders to obtain the patient's baseline mental status. Review medications, medical alert bracelets, and any other health-related items for relevant clues. Be sure to accurately document the patient's level of consciousness over time. Consider using the Glasgow Coma Score to provide precise measurements of the patient's responses. Remember, with the Glasgow Coma Score or the GCS, it should always be the same patient that's doing the measurements or providing that precise measurement, because what my opinion is and what your opinion is of the patient could be two different things. In this section, we're going to talk about diabetes. All right, diabetes, glucose, and the digestive system. Glucose is a form of sugar, so it is the body's basic source of energy. Body cells require the glucose to remain alive and to create energy. After sugar and carbohydrates are converted to glucose, glucose is then absorbed into the bloodstream. Glucose is a large molecule and cannot pass into the cell without insulin. So the pancreas secretes the insulin when the blood glucose exceeds 90. And then the insulin binds to the receptor sites on the cells and allows the glucose molecules to pass. Normal glucose levels in the blood are essential to maintaining normal mental status. Here is the diagram of the insulin and blood sugar that combines to enter the cell. That's where the insulin is needed to help the cells take in that glucose. So patients who are diabetic do not produce insulin. They do not produce enough insulin or have become resistant to the insulin that is produced. All right, next we're going to talk about the insulin and the pancreas. So the islets of Langerhans is the pancreas that produces the hormone insulin. So most cells out of the brain use insulin to transfer large glucose molecules across the cell membrane. So insulin is a key that unlocks those cells, and once unlocked, the glucose can then enter. So when sugar intake and insulin production are balanced, the body effectively uses the glucose as an energy source. Next, we'll talk about diabetes mellitus. So diabetes mellitus is a result from an underproduction of insulin or the ability of the cells to use insulin properly. Type 1 diabetes is formerly known as the insulin-dependent diabetes. The pancreas or pancreatic cells do not function properly. The insulin is not secreted normally, and there is too little insulin to transfer circulating glucose into cells. Synthetic insulin is typically prescribed to supplement inadequate natural insulin. Next one is type 2, which is formerly known as the non-insulin dependent diabetes. That's when the body's cells fail to utilize insulin properly. The pancreas is secreting enough insulin, but the body is unable to use it. It may be controlled through diet, oral anti-diabetic medications, and sometimes insulin. Next, we'll move on to diabetic emergencies. So first is hypoglycemia, which is low blood sugar. It is caused by too much insulin, too little sugar intake, over-exercising or overexertion, vomiting, and increased metabolic rate. When the blood sugar is reduced, the brain and the body cells starve. Hypoglycemia leads to altered mental status, unconsciousness, and possible permanent brain damage. The onset is rapid, and the signs include abnormal behavior mimicking a drunk stupor. They can be pale and sweaty skin. They can be tachycardia, rapid breathing, and possibly seizures. Quick replenishment of blood sugar is critical to the outcome for a patient with hypoglycemia. Oral glucose is often used. Cells of the RAS in particular need glucose, which causes notable alterations in mental status. Next is hyperglycemia, which is high blood sugar. It is caused by insulin deficiency. The body may be unable to produce insulin, and insulin injections may be forgotten or insufficient. Infection, stress, and increased dietary intake are factors. Hyperglycemia develops over days or weeks. Signs include chronic thirst and hunger, increased urination, nausea, and dehydration. The cells of the body slowly starve because glucose cannot enter the cells from the blood. Starving cells begin to burn fats and proteins in a way that produces excess wastes. Waste build up and combined with dehydration to cause diabetic ketoacidosis, or also known as DKA. Signs of DKA include profoundly altered mental status, shock, which is caused by dehydration, rapid breathing, and acetone odor on the breath. During your patient assessment, you want to ensure scene safety. The patient could be agitated or even violent. You want to perform your primary assessment in identifying the altered mental status. You want to perform a secondary assessment, gather a history from the patient or the bystanders. Next, you're going to gather a history of the present episode. Determine how the episode occurred, the time of the onset, and the duration. Identify associated symptoms, any mechanisms of injury, and any interruptions to the episode. Ask whether there have been seizures or fevers. Then you're going to complete your sample history. Determine if there is a history of diabetes. You're going to look for any medical ID bracelets or a wallet card. Note any oral medications. Check for a home glucose meter. And watch for an implanted insulin pump. You're going to perform a blood glucose monitoring if local protocols permit you to do so. Determine if the patient is alert enough to swallow. Take the baseline vitals. And then observe for sites and symptoms of diabetic emergencies. Rapid onset of altered mental status, intoxicated appearance, cold, clammy skin, elevated heart rate, and hunger. Observe for signs and symptoms of diabetic emergency, uncharacteristic behaviors, anxiety, combativeness, and seizures. It is important to determine both hypoglycemia and the ability to swallow to administer effective field treatment. Next, we're going to talk about blood glucose meters. Blood glucose meters makes it possible for patients to test glucose levels in their blood every day. Testing helps patients know how much insulin to take and when and how much to eat. Testing helps reduce diabetes-related complications. Continuous glucose meters can test as often as every 5 minutes via a sensor under the skin. EMTs should not use a patient's glucose meter. Here is a typical diabetic home glucose meter to test their glucose levels. So with the blood glucose measurement, less than 60 in symptomatic diabetics indicate hypoglycemia. Less than 50 causes significant alterations in mental status, including unconsciousness. Greater than 140 indicates hyperglycemia, and greater than 300 for a prolonged period leads to dehydration and other more serious symptoms. You always want to question a reading that is inconsistent with the patient's symptoms. So the test strip may have had too little blood, been expired, or been improperly stored. The meter may have been out of calibration, or the meter may have not been used properly or properly maintained. Glucose meters have special display readings for very high or very low glucose values. A reading of high indicates extremely high levels in excess of 500. A reading of low indicates extremely low levels, typically below 15 milligrams. Again, going back to that last slide, you always treat the patient, not the monitor. The monitor is a tool in the toolbox. Your patient is what should drive you to making your decisions. All right, patient care for the diabetes patient. Occasionally mild hypoglycemia and minor altered mental status can be treated by eating or drinking. Determine if the criteria for administration or oral glucose are present: a history of diabetes, altered mental status, or the patient is awake enough to swallow. If the patient meets this criteria, let him or her squeeze the glucose from the tube directly into their own mouth. You want to reassess after the patient has administered that glucose. If there is no improvement, consult medical direction. If the patient is unable to swallow, treat as you would any other patient with an altered mental status. Secure their airway, provide artificial ventilations, and be prepared to perform CPR as needed. If ventilations are not required, place the patient in a recovery position and request ALS. The most important decision point in choosing to give oral glucose is the patient's ability to swallow. A hypoglycemic patient may need the sugar, but if the airway cannot be protected, oral gel is not appropriate. Only administer oral glucose to patients who can swallow and protect their own airway from aspiration. Hypoglycemia and hyperglycemia compared. So the onset. Hyperglycemia has a slow onset, where hypoglycemia tends to come on suddenly. Skin in a hyperglycemic patient involves warm, red, and dry skin. Hypoglycemia involves cold, clammy skin. Their breath. Hyperglycemia involves acetone breath, where hypoglycemia involves no specific breath smell. Patients with hyperglycemia may also breathe deeply, be intensely thirsty, and have abdominal pain or vomiting. It is not necessary to distinguish between the two conditions to give the proper treatment in the field. Oral glucose is recommended for anyone with a diabetic emergency. It helps hypoglycemic patients and it will not harm hyperglycemic patients. All right, in this section we're going to talk about other causes of altered mental status. The first one we'll talk about is seizure disorders. If brain function is upset by injury, infection, or disease, the brain's electrical activity can become irregular. Irregularity can bring about a sudden change in sensation, behavior, or movement called a seizure. Partial seizure affects only one part of the brain. It may involve uncontrolled convulsions in a patient with fully alert mental status. Some patients may briefly lose consciousness without convulsions. Generalized seizures affect the entire brain and affect the consciousness of the patient. EMTs are most often called for the type of generalized seizure called a tonic-clonic seizure. It is characterized by unconsciousness and major motor activity. It often has no warning, and the patient will thrash wildly and the entire body is involved. Tonic-clonic seizures have 3 phases. The tonic phase is when the body is rigid for up to 30 seconds. Breathing may stop, and bowel and bladder control may be lost. In the tonic phase, the body jerks violently for 1 to 2 minutes. The patient may foam at the mouth. The face and lips may become cyanotic. And last, the postictal phase. The convulsions have then stopped, consciousness is regained, but the patient may be drowsy or may be violent. So be prepared. Some seizures are preceded by a sensation. Sometimes they talk about a smell, a sound, or a general feeling. That's called an aura. The most common causes of seizures in adults is failure to take prescribed anti-seizure medication. The most common cause of seizures in infants and young children is high fever. Other causes of seizures can include hypoxia, stroke, and traumatic brain injury. Other causes can be toxins, hypoglycemia, brain tumor, congenital brain defect, infection, metabolic, and idiopathic. There's also epilepsy, measles, mumps, and other childhood diseases, eclampsia in the pregnant female, heat stroke, and onset of syncope episodes. Epilepsy is an umbrella term used to describe multiple seizures of known causes. It may be present from birth or may develop later due to injury or surgery. Medication allows most people with epilepsy to live a normal life without seizures. For your patient assessment, it is important to describe the seizure to emergency department personnel. You want to gather information by asking bystanders, what was the person doing before the seizure started? Was there an aura? Exactly what did the person do during the seizure? Was there a loss of bladder or bowel control? How long did the seizure last? What did the person do after the seizure? During patient care, a patient is seizing on your arrival, it is a priority to transport. If you are present when a convulsive seizure occurs, you want to place the patient on the floor or the ground. Loosen any restrictive clothing. Remove objects that may harm that patient. Protect the patient from injury, but do not try to hold the patient still during the convulsions. If there is a vagus nerve stimulator, allow family members to apply the magnet. After a convulsion has ended, you want to be sure to protect the airway. If the patient is cyanotic, ensure an open airway and provide artificial ventilations with oxygen. Treat any injuries the patient may have sustained during convulsions and transport to a medical facility. Never place anything in the mouth of a seizing patient. 2 or more convulsive seizures in a row or a single seizure of more than 10 minutes is considered status epilepticus. This is a high priority emergency requiring immediate transport to the hospital. ALS intercept may also be necessary. Next, we're going to talk about the types of seizures. So the first one is a simple partial seizure, which involves tingling, stiffening, or jerking of one part of the body. An aura may occur. There is no loss of consciousness. In some cases, the jerking may spread and develop into a tonic-clonic seizure. Complex partial seizure is characterized by abnormal behavior that varies widely. It may involve confusion, glassy stare, aimless motion, lip smacking, or fidgeting. The patient may appear to be drunk or on drugs. The patient is not violent but may struggle if restrained. Seizure is often preceded by an aura, and there is no loss of consciousness, but there is no memory of the episode. Generalized seizures include 2 types. The first one is an absent, or what's also called a petit mal seizure. It's brief, for 10-second temporary loss of concentration or awareness. It may occur hundreds of times per day, and it does not involve any motor activity. The tonic-clonic seizure involves the entire body. Patients with epilepsy tend to be knowledgeable about their condition and seizures may be common. They may refuse transport. Ensure patients who refuse transport are not left alone and do not drive. Next, we're going to talk about stroke. Stroke is the death or injury of brain tissue from oxygen deprivation. Ischemic stroke is caused by a blockage that occurs due to a clot or embolism obstructing the artery. Hemorrhagic stroke is caused by bleeding from a ruptured blood vessel in the brain, often a result or a long-standing high blood pressure. It can also occur when a weak area of an artery bulges and eventually ruptures. Different patients exhibit different signs depending on the size and location of the arteries involved. One-sided weakness, also known as hemiparesis. Difficulty speaking or the complete inability to speak. Headache caused by bleeding from ruptured vessels. Deviation of the eyes, or inability to recognize parts of the patient's own body. Communicating with the stroke patient can be difficult because damage to the brain affects the word use. Aphasia is a general term for difficulty communicating. In expressive aphasia, the patient knows what they are wanting to say, but uses the wrong words. In receptive aphasia, the patient cannot understand you, so it responds in ways that doesn't make sense. Next, we're going to talk about transient ischemic attack. In transient ischemic attack, also known as TIA, the patient exhibits stroke signs that resolve within 24 hours. Small clots temporarily block circulation to part of the brain and causes stroke-like symptoms. Symptoms resolve when the clots break up. The period of hypoxia is short and there is no permanent damage. The patient is at risk for a full-blown stroke and should be evaluated as soon as possible. During your patient assessment, you want to evaluate using the Cincinnati Pre-Hospital Stroke Scale. Ask the patient to grimace or smile. Any abnormal response is unequal or no movement. Ask the patient to close the eyes and extend the arm straight forward for 10 seconds. Abnormal response is for one arm to drift or not move, or for the arms to turn. Here's how you assess for arm drift by asking the patient to close his or her eyes and extend the arms, palms up for 10 seconds. The patient who has not suffered a stroke can usually hold her arms in an extended position with the eyes closed. Here, when you assess for arm drift by asking the patient to close her eyes and extend her arms palms up for 10 seconds, a stroke patient will often display arm drift or palm rotation. That is, one arm will remain extended, but the other arm on the affected side will drift downward or turn over, just like in this picture. You want to evaluate again using that Cincinnati Pre-Hospital Stroke Scale or whatever your local protocol says. Ask the patient to say, "You can't teach an old dog new tricks." Abnormal response is slurred speech, wrong words, or no speech at all. All right, in this diagram, they are assessing for speech difficulties. So a stroke patient, remember, will often have slurred speech, use the wrong words, or be unable to speak at all. Other signs and symptoms can fluctuate in severity. Confusion, dizziness, numbness, weakness, or paralysis often on one side, loss of bowel or bladder control, impaired vision, high blood pressure, and difficult respirations or snoring. They can also have nausea or vomiting, seizures, unequal pupils, headache, loss of vision in one eye, or unconsciousness, which is pretty uncommon. Recognition is the most important step in stroke care. Many conditions mimic stroke, but it is always better to overtreat a suspected stroke patient. Stroke is a time-sensitive, and the longer the vessel is blocked, the more damage that will occur. The most important treatment is often rapid transport to an appropriate destination. For a conscious patient who can maintain their airway, you want to help them remain calm and reassure the patient. Monitor their airway. Administer high concentration oxygen if saturation is below 94% or if hypoxia or distress are present, and then transport the patient. For an unconscious patient or a patient who cannot maintain the airway, you want to maintain an open airway, administer oxygen for adequate oxygen saturation, and transport to a hospital with capabilities to manage a stroke patient or per your local protocols. Use of some treatments is time sensitive. Patients must meet specific criteria for clot busting drugs. Onset of stroke less than 3 hours prior. CT scan showing no evidence of hemorrhagic stroke. And blood pressure that is not excessively hypertensive. Be sure to document the exact time of symptom onset. Next, we're going to talk about dizziness and syncope. Dizziness and syncope can indicate serious or life-threatening problems. You may be unable to diagnose the cause of the syncope or other causes of altered mental status, but you can treat life threats and gather the information. You want to determine what the patient means by dizziness. Is it weakness, vertigo, or lightheadedness? Syncope is a brief loss of consciousness with a spontaneous recovery. Patients often have some warnings that a syncopal episode is about to occur. They may experience lightheadedness, dizziness, vision changes, or sweating. In some cases, bladder or bowel incontinence may occur. Some causes of dizziness and syncope can be cardiovascular causes, either bradycardia or tachycardia. Could be acute myocardial infarction, abnormal heart anatomy, sensitive carotid sinus, or stimulation of the vagus nerve. Hypovolemic causes, which is low fluid or blood volume, dehydration, internal bleeding, or trauma. Then you have your metabolic and structural causes, with the inner and middle ear problems, hypoglycemia, stroke, and seizure. It could also be from environmental and toxicological causes. It could be alcohol, drugs that depress the central nervous system, carbon monoxide poisoning, panic or anxiety attacks. In other causes, in half of the cases, no cause is ever even found. You want to rapidly identify and treat the life threats. Ask questions to gather important information during the secondary assessment. Describe what you mean by dizziness. Did you have any warning signs? If so, what was it? When did it start? How long did it last? What position were you in? Have you ever had any similar episodes in the past? You should also ask, are you on any medications for this kind of problem? Did you have any other symptoms or signs? Did you witness any unpleasant sight or experience a strong emotion? Did you hurt yourself? Did anyone witness involuntary movements of extremities like seizure activity? The greatest danger for a patient with syncope is falling. Ensure the patient is in a safe environment. Help the patient into a safe position on the floor. Provide aftercare. Lay the patient flat, loosen any tight clothing around the neck, administer oxygen, call for ALS, and treat any injuries the patient may have incurred. All right, let's do a quick chapter review. Diabetic emergencies are usually caused by ineffective management of the patient's diabetes. Diabetic emergencies are often brought about by hypoglycemia or low blood sugar. The chief sign of this hypoglycemia is altered mental status. Whenever a patient has an altered mental status, a history of diabetes, and is able to swallow, administer oral glucose. Seizures may have a number of causes. Assess and treat for possible spinal injury. Protect the patient's airway and provide oxygen as needed. You should gather information about the seizure to give to hospital personnel. A stroke is caused when an artery in the brain is blocked or ruptures. Signs and symptoms of a stroke commonly include an altered mental status, numbness or paralysis on one side, and difficulty with speech. For stroke patients, you want to ensure an open airway and provide supplemental oxygen. Determine the exact time of the onset of the symptoms and transport promptly. Dizziness and syncope or fainting may have a variety of causes. In the case of syncope, loosen clothing around the neck and place the patient flat with the raised legs if there is no reason not to. Treat any injuries and transport. In all patients with altered mental status, your decision to administer oxygen will be based on the pulse oximetry reading as well as the patient's level of respiratory distress and other signs of hypoxia. Remember, determine whether the patient's altered mental status is being caused by hypoxia. In a patient with a hypoglycemic emergency, determine whether the mental status will allow the administration of oral glucose. Assess the seizure patient to determine the need for artificial ventilation. Determine when the symptoms of a stroke began. List the chief signs and symptoms of a diabetic emergency. Explain how you can determine a medical history of diabetes. Explain what treatment may be given by an EMT for a diabetic emergency and the criteria for giving it. Questions to consider. Explain the care that should be given to a conscious and to an unconscious patient with suspected stroke. And explain the care that should be given to a patient who has experienced dizziness or syncope. Remember, stroke patients should receive airway management when necessary. High flow oxygen and rapid transport are also important. As far as syncope and dizziness goes, often point to more significant underlying problems. You want to always complete a thorough patient assessment and transport the patient lying flat while administering high flow O2. Critical thinking. You have a 62-year-old male who is witnessed to have a tonic-clonic seizure. You find him actively seizing. His skin is pale and moist and slightly cyanotic. Discuss the immediate treatment necessary. So remember, cyanotic skin demonstrates the need for immediate airway management and high concentration of oxygen. Once the airway has been secured, the primary assessment must be completed. Rule out any life-threatening causes of the seizure like hypoxia, hypoglycemia, and stroke. If you have any questions, as always, please reach out to your instructor. Thank you and have a great day.